My name is Darcy, and I am kind of the physician assistant that if you choose to sign up for a clinical trial, I will be the front line to help you manage your side effects and keep everything kind of on track for you. So, as Amy said, the team is the treatment room nurses. You're going to see them for every treatment when you're in the treatment room. The doctors and the advanced practice providers, so that's primarily me if I'm not here. Melissa and Ashley are always around to help answer everything, and obviously they're wonderful as well. And the research coordinators and the RAs that Amy said. So what are you going to expect on your treatment day? Some of this is a little bit repetitive from what Amy said, and I'll go over all of these in a little bit more detail coming up. So you're going to get your blood work. We always draw labs, almost every treatment. This is going to happen. EKGs, biopsies, physical exam, management of adverse events. So this is a big one that I'll talk about in a minute. The pharmacy. What is the pharmacy doing when you're in here for treatment? And then you'll get the drug and observations, vitals, labs. So let's talk about this a little bit. Your labs are required for almost every treatment. The majority of you will get them every time you're here. You also will have research labs. So what's the difference? The research labs go across the hall to the research team. We don't need those to be resulted for you to be cleared for treatment, whereas the standard of care labs, those are what I'm looking at. That's what I need to come back before we can clear you for treatment. And that's incredibly important because that tells us how your body is reacting to the drug. Are you having any adverse events that we need to hold your treatment for? We do lots of EKGs, especially for the newer drugs, because we're using that to monitor for any drug-related changes. So you may have trials where you get multiple EKGs in one day. You may have trials where you get an EKG, on cycle 1 and 3 and 6. So there's not a standard thing that I can tell you you're going to get an EKG these times. All these things are pretty dependent on the trials, and every trial is different. So biopsies. This is another really important one that we have to do these biopsies to really help us determine not necessarily what your staging is, because this has already been done prior to you signing up for the clinical trial. But this is, again, something that we use to help determine approval for the trial. What kind of changes are being made in the cells? So we like to do a lot of times a pre-treatment biopsy, and then one after you've had so many cycles of the treatment. And that doesn't necessarily get sent to pathology, but it is really helpful in determining whether or not this drug is working and if it's going to be approved. Physical exam, that's what I do. This is required for most treatment days, and this, again, our most important thing is to make sure that you're not having any adverse events that would harm you. And so that's what I'm here for, to help talk about how you're feeling, how's your fatigue, how's your energy, are you having any rashes? We talk about this all the time. Bowel movements, all this stuff we talk about every time you come in. So let's talk about adverse events. What is an adverse event? This is defined as any untoward medical occurrence associated with the use of a drug in humans, whether or not it's considered drug-related. So what does that mean? Any lab abnormalities that come up, any subjective complaints that you tell me about. And this is why I have a list of questions that I ask every time you come in, even if you tell me every time, no to everything, I still have to ask all these things. Objective exam findings, of course, and then things that we can see on imaging. So if you are getting restaging scans and we see something called pneumonitis, which is an inflammation in the lungs. I know some of my patients are familiar with that. We grade that, and that really helps us determine what the next step is. So every protocol has a specific wording in the protocol that tells me what do I need to do with this finding. And we use the CTCAE, the Common Terminology Criteria for Adverse Events, to determine what grade that is. I actually have an app on my phone that I can type in any of those things, and they help me determine what the grade is. So this is just a little example that I found online of different grading, how they do it. So you can see for anemia, so low hemoglobin, if it's 10 to the low limit of normal, that's a grade 1. So these are considered mild, sometimes asymptomatic is grade 1. A grade 2 anemia is going to be a hemoglobin between 8 and 10. So this is more moderate symptoms, not necessarily transfusion indicated, but certainly something that we need to monitor. A grade 3 is going to be a hemoglobin of less than 8. Generally, transfusions are indicated at this point. And so you can see for the neutropenia, those are the low neutrophils. If you're between 500 and 1,000, that's a grade 3. And the thrombocytopenia, which is low platelets, between 25,000 and 50,000 is a grade 3. So why is this important? So most protocols are going to tell us, especially mostly at grade 3, this is a problem. This is affecting the patient. We need to hold your treatment. And then they also will tell me, what do we do about it? So for, an anemia, most likely you would just do a blood transfusion and then, recheck it, the hemoglobin at certain points. But I think the more, concerning things that we see about, so back to the pneumonitis. So I just had a patient on Friday have a grade 1 pneumonitis. So according to the CT-CIE, this is asymptomatic. It's seen on imaging only. So, I spoke to her. I asked her if she had any coughing, if she had any shortness of breath or fast heart rate. We did a walking pulse ox with her. At rest, she was at 96, and she stayed at 96 while we walked up and down the hall in the treatment room. She did not have any tachycardia, which is a fast heart rate. So Dr. Devar and I saw her together, and we discussed that with her and referred to the protocol, which I'll get to in my next slide. So what happens when an adverse event is noted? Number one, for the clinical trials, we always refer to the protocol because they're all a little bit different. So there's not one set rule that I go by. I review the protocol every time. This can take a little bit longer when you're in the treatment room, and sometimes, most of the time my patients are very understanding of that, and I appreciate it, but this is something that we really have to pay attention to, and we can't just say, oh, I think you're fine, we'll just do this. I look at this every time. So for this patient with the grade 1 pneumonitis, the protocol said to hold treatment and rescan at least every 3 weeks, consider referral to pulmonology. She was asymptomatic, and she's a good historian. I trust her to call me if something changes. So we did not do that at this point, but that is something that we could always do. So we'll see her back in 3 weeks with another chest CT and go from there. So the protocol says that for this specific patient, if her pneumonitis resolves to baseline, meaning back to nothing, then she gets to restart her treatment. If there is still evidence of that inflammation in the lungs present, then we'll hold her treatment and rescan in another 3 weeks and go from there. So like my slide says, every protocol is going to be different, and sometimes these requirements are a little bit more strict than what you would see with standard of care. This can be frustrating sometimes for me as well as you, but we really have to go by what the protocol says so that this data can be evaluated effectively. Now, when can I restart my treatment if I have an adverse event? Again, refer to the protocol. This is something that I definitely talk about a lot with my patients. So most protocols, let's say you have a grade 3 sodium. Most protocols allow the treatment to be restarted once they've improved to a grade 1 or better. The problem with sodium is it doesn't have a grade 1, so it has to be resolved to within normal limits, to the normal level. We kind of go over this. I talk to Melissa all the time when I have issues with this, but it really is, like I said, it's important for your treatment. If, unfortunately, this has happened, if your treatment has to be held for greater than 12 weeks and the adverse event has not improved to a grade 0 or 1, you may have to permanently discontinue your treatment. Again, this is written into the protocol. We've had instances where we've been able to contact the sponsors and they grant an exception or a planned deviation for us to continue. This is absolutely on a case-by-case basis. And if we feel it's in your best interest to continue the treatment, that is something that we would consider. So Melissa and Ashley are going to talk about management of these adverse events and what we do when they happen, as far as do you need steroids and things like that. So they'll go over that stuff a little bit more. There are some treatments, not too many right now, that have dose reduction. So if you were on pegylated interferon and your fatigue is a grade 3, meaning that you're sleeping most of the day, you're not completing your ADLs and things like that, then we're going to dose reduce. We'll hold it for a certain amount of time and then dose reduce. And those dose reductions are built into the protocol as well, and they'll tell me exactly what your dose is going to be if you have to dose reduce. The things like the pembrolizumab, which I have a lot of combination trials with pembrolizumab, that doesn't get dose reduced. It's either you get it or you don't. But interferons or dabrafenib, trametinib, those can get dose reduced. So that's something else that I really, again, refer to the protocol. If you have anything wrong during your treatment, I'm reading your protocol, just to remind myself, because they are all so different. So once you're cleared for treatment, what happens? The infusions and the injections are prepared by the general pharmacy that staffs the entire cancer center. So it's Beckwith and CTRC, floor 2, 3, and 4. The one pharmacy does all those drugs. If you're getting any oral study medications, our IDS pharmacy, which is Investigative Drug Services Pharmacy, prepares those for you. So they do come from different places. But something that we have to remind our patients is that these medications cannot be prepared until all your labs have been resulted. Your physical exam is completed, which means that you've been seen by a provider. Your orders have to be signed, which generally I can do that after I see you and see your labs. You have to have 2 nursing checks completed and 2 pharmacy checks completed. Then the drugs are made. This does take time. I always try to counsel my patients when they're new about this process because it can be frustrating. And you're saying, why don't you just have my drug ready when I'm here? But as we just talked about, all these adverse events are possible, and we really need to make sure that this is safe. And this goes for standard of care too. That part is not just for a protocol. So why is this happening? We need to ensure the right drug at the right dose for the right patient every single time. So every week is different, every cycle is different. Things can change quickly in this industry, so we want to make sure that you are safe. That's my biggest goal. Now, once you've been cleared for treatment, your orders have been signed, now what happens? So something that's different for the protocols is pre-vitals, EKGs. The length of infusion is determined by the protocol, so that doesn't really change. The dose modifications, as I talked about, like I said, that's written in the protocol and easy for me to refer to. Post-treatment vitals. So we have trials right now that we're doing intratumoral injections in combination with pembrolizumab. So those patients are getting vitals for they come in every week for 7 weeks. The first 3 weeks, they are getting vitals every half an hour for 4 hours after their intratumoral injection. And this is because we can have bad side effects from this, and we need to make sure that we're keeping a close eye on things. This helps us for the future determine, what is really needed. If this drug is approved as standard of care, is that required when that happens as well? And keep a close eye on the patients. And then post-treatment research labs, again, looking at different markers after you receive the drug. Usually if you have it, you'll have like a pre-treatment lab and a post-treatment lab, just one or the other. That varies a lot. And one other thing that I forgot to put on the slide this morning that Amy sort of touched on is when do you stop treatment? I think this is a big question that we've talked about, that I have, this conversation with my patients a lot. So a lot of the protocols will have a specific time period. 2 years is a pretty common one. If it's an adjuvant study, it's usually a year. Some of them don't have an end date. So then you say, do I have to do this for the rest of my life? And the answer is, it depends. So the number one reason that patients come off trials is not number one reason they come off, but the thing that is, that will make you come off of trial is progression. So some treatments will allow, or some protocols will allow treatment past progression if we think it's in your best interest, because we talk about that pseudo-progression, so that's something that we take into account. So if I review your scans or when the doctors review your scans, we kind of talk about what's in your best interest. If it's, if the protocol doesn't allow treatment past progression, then we would have to talk about the next steps and you would have to come off. Another reason that I touched on earlier is going to be unacceptable toxicities. So if you have an adverse event and we're not able to get you back on treatment after that 12-week period or whatever it may be, then again, most likely you would have to come off. Everything's, you know, every treatment's a little bit different. Some of them will allow you to stay on, like I said, on a case-by-case basis. We may make that exception. And then another reason that Amy said as well is withdrawal of consent. If you say to us, I don't want to do this anymore, it's not worth it to me for whatever reason, then you can come off, obviously. And then the last reason is going to be provider discretion. So let's say your trial doesn't have an end date specified in the protocol, and you've been on your treatment for 2 years, and you have either a significant partial response or you have a complete response to treatment. We can say, okay, I think you've done really well on this, your scans look great, so why don't we come off and we'll keep doing serial imaging every 12 weeks or whatever it is. So that is definitely something that has happened and we talk about a lot, always a good thing to see. And, we're always focused on your safety and making sure you're getting the best care. That's it. Any questions?